I want to welcome everyone to the first seminar series of our Implementation Science seminar series, sponsored by the CTSA, Implementation Science Initiative, and New York State Psychiatric Institute. I want to thank my co-directors, Sapana Patel and Natalie Moyes, as well as Milton Wainberg for helping launch this seminar series. We are thrilled. And today, this seminar was actually supposed to happen last spring and didn't. So I am really excited that we are able to have Dr. Sarabeth Broder-Fingert here join us. She has a new position, which I'm so excited about. She is Vice Chair for Clinical Research and Associate Director for Research through the Eunice Kennedy Shriver Center at UMass Medical School. Sarabeth is a pediatrician, health services research, and implementation scientist. She's been working on developing and testing interventions to promote the equity among children with autism spectrum disorder. So she has a very successful track record of getting funded in this area on implementation and dissemination. She's PI of multiple R01 grants that are funded through NIMH to study novel interventions to improve equity in the early diagnosis and treatment of autism spectrum disorder. She's implementation PI for a multi-site randomized control trial of a community-based intervention in this area, and she's going to be sharing a lot of her work that she's been doing, so I'm thrilled to hear about it. She's also an IRI fellow and has over 50 publications in the field. And I've gotten to work with her really closely this past year, really maybe 18 months now, as we've been part of CARDIS, the Collaborative for Anti-Racism Dissemination and Implementation Science, as part of the organizing team. So it's been a thrill to get to know her, and I'm so excited to learn from her today. So I will hand it over. So we will have her present and try and leave about 10 minutes at the end for questions when I'll unmute everyone. So thank you, Sarabeth.
Wonderful. Thank you, Rachel. Thanks for inviting me. So today I'm going to talk about using implementation science to address issues of structural racism for autistic youth. And the first thing I want to mention is that I'm already in trouble because I put here that I am Vice Chair for Clinical Research and Associate Director for Research at UMass Medical School, but it's no longer UMass Medical School. We are now the UMass Chan School of Medicine. I'm also an alumni of the Harvard Chan School of Public Health. So I'm pretty sure it's about me. That's where all the funding is coming from. But anyways, hopefully no one from the Chan group is on this call to get me in trouble. But I have nothing to disclose. I have some funders. So I'm going to very, very briefly talk about what is structural racism. I'm going to give also a very high overview of what autism is, because I assume not everyone on this at this talk has a deep understanding of autism. I'm going to talk about implementation science, and then I'm going to talk about how they all intersect. And one of the things that I've really enjoyed in creating this talk is, as our friend Corey Bradley says, like a critical reappraisal of everything. One thing that I really try to do in thinking about this is that we really need to reappraise the work that's been done in the past to be able to move forward in an equitable way. And I think the best place to start is with yourself. So for those of us who've been in the space long enough to sort of have a critical body of work, I'm hoping to show some of my work and how I've actually been rethinking some of the work that I've done in the past through a more equity and structural racism lens. So the first thing I always like to talk about is how important language actually is, especially the way that we talk about things. So the first thing I want to address is this issue of autism versus autistic, because it comes up a lot. And if you're in the weeds in the field of autism research, it's a topic of very frequent conversation. Should people be referred to as autistic or a person with autism? And some people will call it person first versus disorder first language. And I don't think that there is a correct answer. That's my personal opinion. Others would strongly disagree. But I can just give you two examples of different opinions on this topic. So this is a parent of a child that I have taken care of who said, growing up, my son was mocked and teased as the quote, autistic kid. I hate that word. Do not call my son autistic. And that parent feels very, very strongly that they never want me to say your autistic child, but they want me to say your child with autism. On the other hand, we have the voice of someone who calls themselves autistic. I'm autistic. I'm proud of that. It's not a disease I caught. It's part of who I am. So I think I now stand in the place that I think every person has a right to be called whatever they want to be called. And if you feel like you're an autistic person, then that's what you should be called. And if you feel like you're a person with autism, that's what you should be called. And at the moment, the solution I have for this is to actually talk to people and ask them how they like to be referred to and use that language. But I'm sure there will be questions that come up about that, and I'm happy to talk about it more. I think the same thing with talking about disparities versus structural racism, and I'm going to talk about this a little more when I talk about critically reappraising my own work. So they do have different definitions. Disparities are often thought of as differences or a difference linked with social, economic, or environmental disadvantage, while structural racism is defined as inequities rooted in the system-wide operation of a society that excludes substantial number of members of particular groups from significant participation in major social institutions. And I think there's a lot of overlap, but unfortunately, traditionally, disparities was often used as sort of a euphemism for structural racism. And again, I think in talking and using our language carefully, we want to make sure that when we're talking about structural racism, we're actually calling out structural racism and not using words like differences or disparities if we're actually talking about structural racism. So I also will try to do that. I think that this was sort of more pertinent like 6 months ago, maybe, but there was like a very small group of people, I think this debate about whether structural racism actually existed in medicine, I think that that's not a question to even be asked, but I just wanted to make it clear that I do in fact believe structural racism exists in the field of medicine. And this is a really awesome paper by Clarence Grabley. I don't know if I'm saying this person's name right because I don't know them, but I thought their definition was really good and pertinent to the talk, so I wanted to use it. What makes racism structural is the way it is interwoven into a series of linked, mutual reinforcing systems: education, policing, banking, housing, employment, immigration, land use, election, healthcare, and more. So that is going to be actually the foundation of the talk, and I'm going to talk a lot about how specifically autistic individuals have to traverse a number of these systems in order to get the services that they need. And therefore, these systems reinforce themselves and can cause a lot of challenges. So now I'm just going to go into very briefly what is autism for those of you who don't have a lot of experience. So it's a developmental disability. It can cause significant social communication and behavioral challenges. But I think what's really important to remember is there's often nothing about how people in this definition they use with ASD. This is from the CDC, sorry, look, that sets them apart from other people, but sometimes there are significant needs. So it's really a broad spectrum. Some people need more support and some people need less support. So I'm just going to show a little video if I can get this to work. Hey.
This 14-month-old child shows signs of ASD. Notice how his attention is so focused on the toy that he does not interact with the people nearby. He does not share his attention with others. His exploration of the toy is also unusual. He drops the toy onto the table and watches it move. When the toy stops moving, he does not use eye contact, vocalization, or gesture to ask for help.
So we can move on, but I think what I really like about that video, which is from Kennedy Krieger, is that that's a 14-month-old with what I consider actually very subtle signs of autism. I think if you're not an expert, you may watch that child play and think that there's nothing that's atypical about that child's behavior. And I think that's important to remember as we're thinking about autism, especially early in childhood, but even across the lifespan, that sometimes signs and symptoms are very obvious and sometimes they're not. So again, just a little more background on autism. The prevalence has been skyrocketing over the past 20 to 30 years. So in 1975, it was 1 in 5,000. In 2009, it was 1 in 110, and it's now up to 1 in 54. So that's a really dramatic rise in prevalence over time. And autism is associated with a number of comorbid conditions. So I tend to focus on children, so I often say children, but really every autistic individual has an increased risk of gastrointestinal challenges, depression, anxiety, seizure disorder, sleep disorder, and the list actually goes on. But the prevalences are particularly high, particularly in mental health comorbid conditions. They can be up to 70% in some studies. But here's where we get to the meat of the talk, which is the different systems that autistic individuals have to traverse to get treatment, and why structural racism is such a problem. So I'm going to focus on a couple, but there are really a lot more. So there's school, there's home, there's the medical system. But I think that actually I like to use a social ecological model in thinking about these different systems, although I sort of changed it because I think one of the things it doesn't display well enough is the interaction and the mutual reinforcement of these systems. But if you think about, these are all the different systems, and this is just a broad overview. There are clearly more that individuals have to interact with to get treatment and services for autism. So I'm going to just focus today on the medical system and the state system. And the reason is because I only have an hour. And if I were going to talk about the school system, I'd probably have to come back like 3 more times alone. So I'm just focused on this, but I think the principles remain across all systems. So I think anything that we talk about today can be applicable to other systems as well. So just as a reminder, we talked about this issue of mutual reinforcing systems. So I'm going to start by talking about the diagnostic process and how which is most primarily sitting in the medical system, although there are other systems that it interacts with, and how these systems can interact to create barriers related to structural racism. So for those of you who are not particularly familiar with autism, early diagnosis is really critical because early diagnosis means earlier treatment, means better outcomes. So there's a lot of focus on getting kids diagnosed early. But there's a big problem, which is that it's really hard to get a diagnosis. So we want kids to get diagnosed early, but the system as it's set up right now is extremely complicated. So this is a study that we published a couple of years ago in the journal Autism, where we just did a process map of getting an autism diagnosis. And ultimately, this is one of 3 maps that we had to create. It doesn't even fit on one slide. And in total, we had close to 70 steps across 4 different systems to get your autism diagnosis. So this is a very complicated process. And as we know, in all systems, as we were talking about, there is racial bias and structural racism that are reinforcing each other. So this is one example that I use that I could have, there's literally thousands where there's evidence of racial bias within the health system. So this was just a study looking at pain treatment. But if you think about it, it then doesn't become surprising. So this is a paper from a colleague of mine, Katie Zuckerman, where she looked at screening for autism. So if you recall back to our process map, which I don't expect you actually do, which is fine, but the first step in getting an autism diagnosis is screening. So if you just look at screening rates, what you find here is that pediatricians report that screening for autism is significantly more challenged in Spanish-speaking families, right? So if the first step in the process is already more difficult for people who speak Spanish or people who are Latino or Latina, then clearly you're not getting off to a good start here, right? And it's therefore not surprising. Again, this is another study by Zuckerman colleagues who found that when you look at actual screening, PCPs report challenges with screening. Well, when you look at the data, not surprisingly, they're screening less in Spanish. So while you look at all types of screening, developmental screening, but autism screening specifically, you find that it's much more likely that a pediatrician will screen for autism in English than Spanish. So as you can see, this is already embedded in the system that we have in place, that screening is happening more often in English for English-speaking families. And then again, this is a paper by David Mandel and colleagues who asked about physicians' concerns about autism. And similarly, they found that when you compare Black to white families, that physicians were much more likely to express concerns about other disorders like conduct disorder or adjustment disorder than autism in kids who had similar symptoms. So again, this is another example of challenges to diagnosing autism that are embedded within the system, that are structurally designed in a way that is biased towards certain populations. And then ultimately what we see, which is not surprising, is that the prevalence of autism is different by race, ethnicity. And I don't think this is surprising at all, because if we say, well, physicians are telling us that they're not screening in Spanish, that they're more likely to identify children as having some other disorder besides autism by race, then it doesn't surprise us in the end that a lot of Black and Latinx and other populations of patients are just less likely to get the diagnosis. And this is actually interesting because for, I think, a while there was controversy and people thought that the true prevalence was actually lower in minority populations, which I actually think is crazy. I think it's very clear that this is systemic racism, that minority or minoritized populations are being missed by the health system. But I think that that's the presiding wisdom now. But there's certainly, it's a topic of debate, I would say. I don't think it's 100% believed yet. And then, not surprisingly, if you look at the family's experience of getting a diagnosis, it creates significant challenges that are also different by race and ethnicity. So this is just a quote from a parent who said, "It took like 4 months to understand autism and find help. I had to look in the mirror and say, what am I doing? What am I going to do? Who do I have to go talk with?" So again, just underlying that this is a really complicated process to get this diagnosis, and it creates challenges for families. But again, the challenges are not distributed evenly. So this is another study by Katie Zuckerman, where she just asked families who are Latino or Latino English proficient versus Latino and they prefer to speak Spanish, their knowledge about different disorders. And this slide's a little bit difficult to look at, in my opinion, actually, but I will say that the take-home point is that English-speaking families report greater knowledge about autism than non-English speaking families. And again, I would hypothesize, and hopefully over the next 5 years, we'll have the opportunity to measure some of these things, that the reason for that is that families are receiving fewer resources and information about this. And then this is a paper by one of your colleagues at Columbia, Ghazi, who looked at English and Spanish-speaking mothers and their report of autism-related symptoms. And again, what you see here is that there are significant differences by ethnicity and what parents are reporting, what types of symptoms parents are reporting, which is really interesting. But it may not go in the direction that you think. So Latino parents actually report fewer symptoms or autistic symptoms in their children than non-Latino parents. And this is actually consistent with a study that we just published, which was not looking at autism symptoms specifically, but was actually looking at stress of the diagnostic process. And we found that in this paper, people identified as Hispanic, but in Latino and Latino populations, that over time, the Latino parents reported significantly less stress throughout the diagnostic process. And we used, in this study, we used additional measures, but the two measures I'm showing here are a specific autism parenting stress index, and then just the parenting stress index. So I think it's interesting to note that these Latino families reported less stress throughout the diagnostic process. And to me, that's actually concerning again for structural racism. My hypothesis is that they actually were provided with less knowledge or information about their child. So it led to lower levels of stress. But again, those are hypotheses that we need to test. So I think for time's sake, I'm not going to go too much more into the parent experience, but I'm happy to field questions about it at the end. But what I do want to say is I do think that there are issues of structural racism, particularly the systems that we have in place for obtaining a diagnosis and the number of systems that need to be crossed that have structural racism embedded in them that impact parents and make the diagnosis more challenging. And then just quickly, I'm also going to talk about the state systems. So at this point, I think most people are familiar with redlining, but I think it's one policy that is a really good example of how state systems can impact autism diagnosis. So okay, so this is a study that we recently published in the Journal of the Poor and the Underserved. And what I think is so important about this study is that it's been known for many years that there are significant differences in autism diagnosis by both race and ethnicity. And the large share of the hypotheses that have come out around this has been it's sort of family factors, like, oh, Spanish-speaking families, like, they don't really want to get the diagnosis. Oh, Black families, they're not engaged as much, like sort of unfortunate racist comments that have been made about the families and sort of putting the blame on them. And what we found in this study, at least, is that the only significant predictors related to sort of where you live and where you get your primary care from. So, as we know, there's a lot of correlation between your race, your ethnicity, and where you live. So what we found is that this sort of undermines a lot of those hypotheses that it's families' sort of desires that are preventing them from getting an autism diagnosis. And we found that it, at least in this study, it's much more related to where you live. And we're actually trying to look at that more broadly. So this is a paper that we published in Pediatrics that just looked at autism diagnosis by state. And I think what's really interesting is that where you live really depends on the prevalence of autism. And again, as I said earlier, there was sort of a longstanding debate. Is the prevalence of autism actually lower in certain minoritized populations? And my thesis is that no, it's not. It's about diagnostic ascertainment. And I think the same thing is true here. I don't think that the prevalence of autism in Florida is double the prevalence in where you are in New York. I think it has to do with whether or not you can get a diagnosis. And then just very briefly, I want to mention this paper, which I think is a really interesting example. It's not about autism, but it talks about how psychotherapy actually is more and less effective. This is by Maggie Price. Depending on where you live and based on the level of anti-Black racism in where you live. So again, it just reiterates this question about not only does where you live impact whether or not you get a diagnosis, but does where you live impact the effectiveness of the treatment you're engaged in? We do not know the answer to that yet, although we do have a multi-site randomized controlled trial going on right now across a number of states where we will at least be able to attempt to ask some of these questions. And it'll be very interesting to see what we find. And just for a little background on this state difference. So there are a lot of state policies that are pretty profoundly different when it comes to autism. So this is just a very brief overview. So, and this is mainly focused on insurance, but as you can see, every state in this study that we have ongoing, which is across 5 states, has different policies related to whether or not you can get autism treatment, what the amount of funds that the insurance has to pay for autism treatment, at what age do you sort of age out of the autism treatment. And as you can imagine, this would likely have profound impacts on outcomes. This is just another way to visualize that, which is, this is a heat map that looks at the funding cap for autism treatment by state. And as you can see, some states will spend a lot of money on treating autism. Some states like Texas will spend almost nothing. And as you can imagine, that may have profound impact on your outcomes. And then this is a recent study by David Mandel that I really like, where they also looked at, they tried to explore this underlying racial and ethnic difference in treatment. And again, this sort of to undermine this idea that it somehow could relate to the parents' desire for treatment or their engagement. Because when they did this decomposition, what they found is that where you lived was by far the most profound indicator of what kind of treatment, and overwhelmed all the other associations related to race and ethnicity. So just to summarize what we know so far, we know that there's structural racism. We know that people have to cross many structures, and that these structures can reinforce these challenges. And what I tried to show is some data that directly shows that both family factors and geographic factors are impacted by the structural racism. But now I want to talk about how can we use the field of implementation science to actually address some of these challenges. So what is implementation science? I think if you're at this talk, you probably know a little bit, but this is the NIH definition. Implementation science is the study of methods to promote the adoption and integration of evidence-based practice, intervention, and policies into routine healthcare and public health settings to improve the impact on population health. So if you want to learn more, I believe that at least folks at Columbia have a very wonderful resource. Although I will say that, I don't think it's on this slide, but Rachel, you can maybe say something at the end about all the training videos that you've made that are publicly available, because they're amazing. I send everyone there. And then if you want to learn more about equity and implementation science, there are a ton of resources, but this just happens to be an upcoming talk that I think is going to be quite good that I would recommend. So how do we think about implementation science and structural racism? So I want to take us through an example of the family-related factors and how we might sort of reframe our thinking on them from an implementation science lens. And I also want to bring in critical race theory, because I think it's a really valuable tool that I'm hoping over time will become more and more embedded in the field of implementation science as we think about some of these things. So we talked a little bit about how children from minoritized populations are less likely to be screened for autism, and therefore are less likely to get a diagnosis. And there are many steps on that pathway, but one possible example is that a family does get screened, but they're given the results and they don't understand the results. So they don't follow up to go get their diagnostic appointment, and then their kid doesn't get diagnosed and they ultimately have worse outcomes. But when we think about if we want to reframe that, we can say, okay, well, why doesn't the family understand the screening results? Well, as I showed before, fewer than half of pediatricians screen in a language other than English. So if they're screening in the not preferred language, well, of course they don't understand the results. And then they don't follow up. Well, of course they don't follow up because they didn't understand the results, and then they have a worse outcome, right? And using critical race theory, you would impose upon this pathway that the problem is not that the family didn't follow up. The problem is that we have a system in place that only screens in English, right? Okay, so to me, that is actually a challenge with implementing autism screening, right? Because we've implemented it only in one language. So I want to use that example going forward to think about how we can use implementation science. So I think there's a couple of really important strengths of implementation science that allow us to think about this more critically. So the first is that implementation science is in its very nature, focus on structures and systems and barriers and facilitators to implementation. So in that example, I would say that a barrier to implementation would be language. And the language issue is an example of structural racism. So implementation science is the perfect field to think about how do we overcome that barrier and thus overcome the racist structure that's embedded into the system. I think implementation science is also really important because it's focused on organizational and individual behavior. And while I think structural racism is really important, I also think we can't overlook individuals' racist practice as either physicians or treatment providers and their own implicit or explicit biases. And implementation science is also a field which is focused on helping change behavior to improve implementation and then also change organizations. I think implementation science has really it's particularly recently become more at the forefront of community and stakeholder engagement, which is also a really important practice in overcoming some of these challenges. This isn't discussed explicitly as much as it should be, but implementation science is in fact a study of who holds power. If we're studying the organizations, that we're studying who hold power, which is really important to think about. And then I also think that the use of frameworks can be really valuable, but can also be detrimental. So I want to talk about that a little as well. So this is EPIS, which has recently become one of my favorite frameworks. And I think in some ways, frameworks can be really helpful because they can help you overcome cognitive biases and avoid cognitive traps when you're designing studies. So if I have my own implicit biases and I think that families are not, minoritized families are not getting diagnosed with autism because I am really focused on the fact that I think the autism diagnostic tools don't actually work that well. If I'm willing to use a framework that allows me to ensure that I'm considering all factors involved, my hope is that it would allow me to see other issues and challenges that help me overcome my own cognitive bias to say, well, actually, there are structural challenges here as well that I don't want to miss. But I think at the same time, they can lead us into cognitive biases because if the frameworks themselves don't explicitly call out structural racism, then we may not measure that. And then we love to talk about structural racism, but then when we go submit our grants to NIH, they say, well, there's no empirical evidence that structural racism is actually existing in the system. So why are you trying to overcome it? And then I say, well, all the frameworks I've used in my entire life have never had that as a variable, so I never measured it. So it can kind of be a double-edged sword. I do want to call out Eva Woodward's health equity implementation framework because I think this has done a nice job, and I think she's coming out with like a even more refined version soon. But it's a nice framework that I think combines or helps overcome some of the challenges where it does address some of these structural issues and deliberately measure some of the things that I think we want to measure. So now in the last 15 minutes, I want to talk about two case examples of how we can use implementation science to address structural racism. And these happen to be examples of my own work. And I think I said at the beginning, I'm taking a page from my friend Corey, who talks about reappraising. And this is basically me taking some studies that I've done in the past and actually trying to rethink them through a racist or an anti-racist lens, hopefully not a racist lens, and thinking about how structural racism played a part in some of the work, and then sort of trying to figure out how do we move forward and understanding what I published in the past and what the meaning of it with this new perspective. So again, we talked about these differences in early diagnosis of autism, and we talked about how there's really a number of failures in implementation of screening and diagnosis. So this is a study that I was part of that looked at family navigation for the diagnosis of autism. And family navigation is a community health worker intervention where community health workers are paired with families and help them get through the diagnostic process. And as you may recall, with the process maps, it's very complicated. So it makes sense that you may benefit from a community health worker who's going to help you traverse all these systems to get through your appointments and get your diagnosis. And this was actually a randomized controlled trial that was published in JAMA Pediatrics last year. But I think what's interesting and important to think about is that what we found was that family navigation did in fact increase the likelihood that you would get an autism diagnosis. So this is just looking at families who had conventional care management, which is the control arm in yellow, and then the blue arm is the family navigation arm. And you can see that the proportion of kids after a year who had gotten through all that complicated process map and made it to the end and actually got evaluated was higher in the family navigation group. Okay, so that's great, wonderful. But where I want to sort of critically reappraise this is when we break this down, we see that, again, in this study, people were asked to identify as Hispanic or non-Hispanic. So if you look at the group, the Hispanic families, you see that there's a much greater impact, right? So the difference between the control and the intervention is huge. And then you look at the non-Hispanic families and you see that the impact, while still significant, was much smaller. Okay. So the initial response to that was like all patting ourselves on the back. Like, we have created an intervention that not only works, but works better in a minoritized population that we know already experiences substantial challenges. Like, isn't this great? Family navigation is an anti-racist intervention where we're overcoming like all these racist structures. But I actually want to challenge us to look a little more closely at the data, because what we actually found is not that family navigation works better in Hispanic families. It's that the control was so much worse in the Hispanic families. So the control condition in the non-Hispanic families, if you look on the right side, you can see they actually did okay, even without the navigators. Whereas among the Hispanic or Latinx families, you can see that without the navigators, they did really poorly. So I think that what this leads me to think about is that we need to think about the systems and the structures that are in place that are leading to these control families from certain populations doing so poorly. And I don't think we can just say that family navigation has solved the problem. We're just going to unleash this large workforce, because I think it's more complicated than that. We have to really be thinking critically about the systems that are in place, and why is it that without navigators, the Latinx families are doing so much worse in that control arm. So this is a paper that's coming out shortly, talking about the lay health worker, community health worker workforce. And what we try to do is think more critically. Also, not sure if I'm supposed to be showing this because it hasn't been published yet, but hopefully it's okay. Think more critically about how lay health workers, community health workers, family navigators actually impact the system itself and how the system responds or doesn't respond, right? Because again, if we just go back to this slide, this was a randomization at the individual level. So one thing that you have to worry about is somehow the addition of family navigators in the intervention arm actually negatively impacting the control arm. Is there something that we're not understanding about why the control arm is doing so badly in this study that I think we really need to better understand? And is there something to do with a supply and demand that we're actually creating greater demand for diagnostic assessments without increasing the supply? And we're actually causing a detrimental problem to the families who are not getting the intervention. So this, I think, will come out soon-ish, which goes into this question in more detail. So again, I think that the initial thought, or our team's initial approach to understanding these results was, we had developed this amazing intervention that was overcoming racial biases and disparities, structural racism, and we should just all celebrate. But in looking at the data more carefully, what I'm trying to do now is say, well, wait a minute, we need to really look at the system and how it's being impacted and better understand. And whether or not part of the issue is the supply and demand issue. I think the other question that I really encouraging us to ask ourselves is that these navigators are almost universally minoritized women, and we're asking them to overcome all these issues of systemic racism in the system. And is that actually a fair thing to be asking them, which is another, again, plug for this paper because it's something we discuss more. So that's the first example. And in the last like 7 minutes, I'm going to give another example, which I have to be honest, can be a little hard to follow if you're not really like deep in the autism space. So feel free to ask questions at the end if you want. But so this has been like a really big topic in the autism space. So in 2016, the U.S. Preventive Service Task Force came out with a statement that said that there was not enough data to support autism screening. And the way the task force makes these recommendations, for those of you who don't know, the task force is supposed to be this independent governmental body that makes recommendations around screening practices. So colon cancer screening, screening for HIV, screening for whatever. So autism screening was a topic that they covered, and they said that there was insufficient evidence. But a big part of their rubric is that it has to be screening in sort of a asymptomatic population. So they said that their statement was related to if you didn't have a family member or health provider who raised concerns already, you were just a kid who walked into your pediatrician's office, no one thought anything was going on, should we screen? And they said, we don't know, is the answer. But what I want to say is that a big problem with that statement is that structural racism was not considered as a part of the equation, and it should have been. So here's the part that's hard to follow, but hopefully it will make sense. So basically what they said is that you have all these kids who are at the top who show up for a pediatrician appointment. And if the family or provider may or may not have concerns about their development or that they might be autistic. So if the family does, then you send them to get diagnosed, then you send them for treatment, and then they get better, right? So that's sort of the pathway that people believe is true. But you have all these kids on the right side where there was no concern. No one in the family, no provider said, I'm worried about autism, but they got screened. And they actually, on the screening test, there was some concern raised. And for I realize, since not everyone knows autism, in case you didn't know, screening for autism is basically a checklist. So you do the checklist and there's some concern raised. So they sent to be diagnosed, they get their treatment. But what the task force said is, we don't know if those kids actually get better. So lots of studies has been done on this population on the left, where someone came and said, I'm worried about my kid. They're not talking. They get sent for a diagnosis and treatment, and then they get treatment and then they get better. But what the task force said is, few studies have been done on this population on the left, where no one was worried about them at all, but they had a positive screen and then they got treatment. So we don't know if they actually get better. But if you remember back to the beginning of my talk, we talked about, well, actually family and provider concerns are very different by race and ethnicity, right? So what if this was not an all-white population of kids, but that this was a diverse population of kids? Well, now you're going to see a different number of characters on one side or the other, because in this population, a lot more people are going to fall on the no parent provider concern, because there's a huge amount of data. You know, I showed probably 20% of it to show that we know there are huge differences. So what happens is this side of the equation, where the task force said, well, we don't know enough information about, this side of the equation is much more likely to not be white kids. And that's a big problem. And there's actually data to show that. This is a study that we published a while back looking at the characteristics of participants who are in autism studies. And multiple studies have now found that they're mostly white kids who are in these autism studies. So the case that I want to make here, again, is thinking about this statement where the task force says there's insufficient evidence to support autism screening. If they're not considering the fact that there's a differential, there's a difference by race and ethnicity on who the family, whether or not a family member or provider expresses concerns, then they're not really doing a fair review of the data. So to me, that needs to be, that whole statement needs to be reassessed using a anti-racist lens. So those are sort of the two case examples that I wanted to give. This is my favorite quote, and I think that it leaves us to this final question of, can we really use implementation science if implementation science is just another tool in our toolbox of sort of NIH-funded research, or can we really move the field to make it different enough that we're no longer using the master's tools? So in conclusion, I just wanted to remind people, so autistic children receive services from a number of different systems that all have certain different levels of structural racism embedded in them that can be reinforcing, that can create great challenges. It really matters where you live. And I showed specific data for autism about that. I really want to implore us to combine the tools of implementation science and critical race theory to really think about how we can use these tools to overcome structural racism. And then finally, I really want to also implore people to think about their own body of literature, whether it's in autism or in another space, and what may have you missed the first time that you may want to rethink in interpreting or understanding your data, and how you can use implementation science to do that. So I have a number of mentors and colleagues that I want to thank for their contribution, and I am, I think, on time, miraculously.
Amazing. Yes, I am so impressed.
I'll leave this up.
Thank you so much. That was amazing. Maybe if you want to bring it to the view of all the
people. Oh, right. Okay. Can I figure out how to do that is a question.
Stop share. Awesome. Thank you. That was amazing. And I really appreciated how you brought together the intersection of so many pieces. And also, I love the idea of the critical reappraisal of our work with that lens. I think that that's really important for us to think about. So I have allowed everyone to unmute themselves. So I'm just going to open it up. If people want to ask questions in these last 10 minutes, either in the chat or just to unmute themselves, that would be great.
If I may start, I guess it's Melodious. Thank you so much. That was a great discussion. I was kind of listening in and out, so I might have missed some things, but I look forward to go back and view it. One thing I had maybe a question, and maybe to kind of get your opinion, is, do you think some of the screening tools that have been developed were mainly on white patients and white populations? And do you know of ways maybe we could approach that? I see patients, I work in, Washington Heights, mostly Hispanic and Latinx. So, in addition to the language barriers that you stated about, some of the things that the screening tools that we use for your different blood work and stuff could be different. But I think when it comes to screening towards like behavioral assessment, I feel like maybe the language, it's not only the language, but I feel like some of the screening tools that we use might also have introduced this racism. So I just wanted to kind of ask your opinion about that. And I don't know if you mentioned and if I missed it, but I don't think I did about the discussion about this. So I just wanted to get your opinion.
Yeah, so I definitely think the tools have been, I just put something in the chat for you too, have been primarily tested on white and English speaking populations, unfortunately. There are a number of efforts to develop new tools. I just put one that I think is pretty good called the developmental check-in, which is mainly picture-based. I think I don't want to get myself in trouble, but what I will say is at the moment it's proprietary, and that's a problem. But with that said, there are certainly efforts to come up with better screening tools that are more culturally appropriate, that are easier to use in different practices. But I do think right now there's a big challenge with the MCHAT is the most commonly used tool, and has not been studied well enough in diverse populations at all, which is a big problem. But I think, so yes, there are efforts being made. I would take a look at what I put in the chat if you're so inclined. And I think there are more, hopefully, tools that are going to be coming out over time. I am interestingly working with my colleague Katie Zuckerman. We have an R21 from NIMH to actually use to look at mobile health screening tools among non-white, non-English speaking populations to better understand what their opinions are about them. Hopefully we'll be able to publish some of that data soon, but it's a big problem. And I think that it's only being addressed really superficially at the moment. I think I'm hoping a lot more work will go into developing better screening tools. But yeah, happy to, if you want to email me, I'm happy to send you more of the data that we have on looking at these different screening tools, if it would be helpful.
Hi, thank you for a great talk. Regarding your last example, can you maybe elaborate of why they decided that it might not be recommended to do this screening? It's just a list check, so it doesn't sound to be very
it's
hard
complicated. So they didn't recommend against it. They recommended. They said that there wasn't enough data to recommend for or against it. And again, I would say it's a little complicated, but basically what they said is that the studies that have been done on autism treatment have all been done on non-screen identified populations. So they've been done on kids who a parent said, I'm really worried about my kid, or the doctor said, something's not right with this kid. Like, we need to get them tested and we need to get them treatment. And those kids do better. But their question was, if it was a kid who wasn't showing any symptoms, and I think by that logic, therefore probably has fewer symptoms, is more mild, and then we put that kid in treatment, would they actually get better? And that's what they're questioning. They're saying, well, if you're not showing symptoms, if your doctor's not worried, if your parents aren't worried, but you screen positive, then your symptoms are probably pretty mild. So then we put you in, we don't really know if the treatment works for that group of kids. So what I'm trying to argue is, unfortunately, that is true if you're white. But as I showed at the beginning of the talk, there's a whole lot of data to show that actually if you're, particularly if you're not English speaking, like that argument completely goes out the window, because pediatricians, you could have a lot of symptoms and pediatricians are not good at identifying kids who are not English speaking, and families are actually reporting fewer symptoms who are not English speaking. So the idea that if no one's worried about this kid, their symptoms are super mild, is actually flawed. So I also wrote a paper on that I can put in the chat if you want, that sort of talks about dismantling that that way of thinking. David Mandel also has a really great paper commentary about this as well that I would recommend.
So I'm new or not yet in the field of implementation science, but I'm just wondering, in terms of addressing this question, which seems that they're not trusting the screening method. So they say the screening method might not really identify or falsely identify kids. But if you're looking at these kids who are on the top after the screening, either because of parental or providers' worry or without, and you're comparing all their symptoms after they get to the diagnosis, can't you show that they're actually not so different before any
I think that's something that people are trying to do right now. I don't think the data is there yet, but I think there are a couple of large studies that are underway that are trying to ask that exact question. But I don't think the data is strong enough yet to just be able to say it. It makes sense logically. I just don't think the data is there.
It looks like Danielle has a couple questions too in the chat. I don't know if you can see those or I can read them. It says, in the U.S. Preventive Service Task Force study that discussed autism screening for children with no parent clinician reported concerns for ASD, were these children without a family history of ASD?
That's a good question. I cannot remember off the top of my head if they excluded there. So another very popular area of autism research is sort of siblings. We know that siblings of autistic kids have are more likely to have autism. So I can't remember if they specifically excluded that group as a higher risk group. My guess would be they did, just knowing their methodology, because usually it's the general population. It's not a high risk population. So my guess is they did exclude them, but I can't remember for sure. I'd have to go back and look. And then the other question Danielle asked was, is there a relationship between family navigation and reducing disparities and the number of false positive and false negative diagnosis? That is a good question. There's no data on that as of right now that I know of, but it is a very interesting question that I think someone, maybe a psychology student, should ask.
Looks like we have time maybe for one last question. I think Ariana has one, and then we'll wrap up. So when it comes to training healthcare professionals to better understand their personal biases regarding race and cultural differences in diagnosis and treatment, what changes have been made on the professional school front to alleviate long-term issues?
Yeah, that's a really good question, and I'm not going to answer it. I'm going to avoid it and give an answer to a different question, which is that I have a whole nother talk that I think is so important around workforce. And I think that's a whole huge another issue around structural racism and workforce. And I think like anti-bias training, which unfortunately I'm not sure works, but that type of that thinking is really important. But I actually think the bigger issue, this is why I'm not actually answering the question, is just the workforce in general and the fact that we don't have capacity to provide diagnostic or treatment services to all the children who need it. And when you don't have capacity, what ends up happening, it's the advantaged people who get the thing. So I think that while the question is really important, and I think that more training needs to happen around that, I think the more important thing is we need to expand workforce capacity to be able to do all the diagnostic assessments that need to be done for these kids and provide all the treatment that need to be provided. Because right now we have a two-tiered system in which those with advantage get all the services, not all the services, get a lot more services than those without. So that's my non-answer to the question.
We are right at 1:00. This has been amazing, so insightful. I love everything you shared, and I hope if people have additional questions, they can reach out to you. But I want to thank you for your time and for kicking the series off. And this will be recorded, so we'll share this with everyone as well. So thanks.
Thank you.
Thanks
Thanks everyone. Take care.